Welcome to Own Your Heart Health. I'm Dr. Regina Druz, your holistic cardiologist. This week, we will dive into common heart health concerns, uncovering root causes, and unpacking scientific discoveries and controversies. The information provided does not constitute medical advice. Please contact your healthcare practitioner before making any changes that may impact your health. Hi, everybody. This is another wonderful opportunity for you to learn. Welcome back to Own Your Heart Health with Dr. Regina Druz, me, and I am here with an amazing guest. This is Dr. Amy Killen, is someone that I met by getting invited to be a part of Longevity Docs. I didn't realize that there was a whole community of longevity docs, right, Amy? And within that community, there is actually a group of ladies longevity docs. So I'm going to put a plug in for incredible Dr. Poonam Desai for putting it together and bringing us all together. But I'm now part of those longevity sisters, and they're absolutely amazing. But today, I wanted to introduce Dr. Amy Killen. Dr. Amy Killen is a remarkable individual. She is a chief medical officer of Hormonal. She is one of the pioneers of longevity medicine, and her extensive knowledge and expertise comes in the field of hormonal optimization. And she actually has a course and a product, and she calls it HOT, Hormonal Optimization Therapy. I believe pun is intended, right, Amy?
Yep.
So Dr. Amy, welcome to the show.
Thank you. I'm excited to be here.
Amazing. So I ask you the same question I ask all of my guests. How did you grow up to be who you are today? Give us an understanding where you come from and how you evolved, into what you're doing right now.
So I grew up in Texas, and I was originally an emergency physician. So I went to school for ER medicine. I got board certified. I worked in the ER in Austin, was in the ER for a total of about 10 years. And kind of towards the end of that, I had my 3 kids within a 2-year time period, twins, and then another one pretty quickly. And my husband had moved away out of state for a job. I'm working 4 a.m. shifts in the ER, lots of stress, not much sleep, crazy times. And I kind of started to feel the impact of that on my own health and my own life. And I also realized, one day when I was looking out at the patients in the ER waiting room, that if I didn't make some pretty big changes in my life, I was going to be one of those patients in 5 years or 10 years with something that was probably preventable, with education and enough work. So I decided to make some changes. And so I decided to learn about how to be healthy, how to prevent diseases, kind of at the time it was like integrative medicine, functional medicine, a little bit of hormones early on. And then I eventually transitioned out of the ER in 2013 and have been doing this ever since.
All right. So it sounds like you and I had similar trajectories, right? We came to that inflection point. And, for me, it may have been, I hold out for a little longer. It was more like 15 years. But, once it started breaking me, I'm like, okay, I have to move on. So tell us a little bit more is that, so the past, let's say 10 to 15 years as you traveled and, actually trailblazed in this vertical of hormonal replacement therapy, integrative therapies. What do you see? Where did it start and what happened in that domain, right? Because right now we have a lot of interesting things happening, both good and bad. So what's been happening in that domain?
Yeah. When I first got started in 2013, I opened a small hormone clinic, preventative medicine, hormones, integrative medicine clinic in Portland. I moved from Texas to Portland on a whim, opened a clinic up there just by myself. I was completely alone, no staff, no nurse, nobody. Like I'm doing all the phone calls and the parking validations and everything. And I was just mostly doing bioidentical hormone replacement. And at that time, all my regular kind of traditional doctor friends thought I was completely crazy. They were like, you are causing cancer. You are hurting people. Like this is, hormones are horrible. We know this. And so I've got a lot of pushback from them, but I had spent so much time reading and learning. And even then, even in 2013, we actually had quite a bit of information about the safety of certain types of hormones and, and the problems with others. And so I felt good about what I was doing, but it was very early days. It was still very like renegade medicine then, but I kept doing it. And I ended up moving to Utah, I had a clinic here that brought me in and I ended up growing that clinic to the largest hormone replacement clinic in Utah, and then have since had other projects as well in other companies. But I've always believed, certainly there's hormones are not they're not magic pills, but they do a lot of good if we use them in the right way. And I think finally in the last few years, we're starting to see, kind of traditional allopathic doctors come around and say, oh, it turns out we were wrong and we didn't understand. And so, it's really good, I think, for women and men.
Yeah, that's very true. And, I remember being a cardiologist at our national meeting. We have a meeting once a year at the American College of Cardiology. And I was just beginning at that time to sort of dip my feet into this whole integrative functional medicine world. And I was in a faculty lounge, and one of the preeminent women cardiologists who established the field of women's cardiac health, truly a pioneer. I had a conversation with her, and I mentioned casually that I'm looking into using hormonal replacement therapy for women. And she immediately shut me down. She said, Regina, just thinking that is a malpractice. and I thought to myself, well, that's not what I read in the medical literature. And that's not what I see clinically. But here's this, preeminent person who is on stages, who is our mentor. How can I, reconcile it? Well, needless to say, years later, we have reconciled it, although there are still things to be done. So let's focus a little bit on, hormones and the heart, because, obviously I deal with a lot of patients, both men and women, who are seeking to optimize their heart health, seeking to optimize their longevity. And so I've learned certain things about hormones and the heart that I didn't expect. And, and that was kind of an eye opener. Like, for example, I learned that many women are looking to start hormonal replacement therapies, and a lot of them either don't appreciate that they have a cardiac risk, or they think that hormonal replacement therapy somehow will make that cardiac risk go away. So what is the data? What do we know about hormonal replacement therapy, both men and women, with relationship to cardiac health?
I think that, there's a lot of questions still, but for women, for instance, I think that I can say that starting estrogen early in menopause, within at least, within 6 years, say, if you want to be safe, starting estrogen early in the menopause transition in someone who doesn't have known cardiac disease is safe and probably reduces your risk of some future heart disease in the future. Now, the problems we have is we don't know the best form. We don't know the best dose. We don't know exactly when that window is. Like, we say between 6 and 10 years is probably when it's most effective, but even that is really, we're not really sure about that. And we don't know exactly what we mean by reducing the risk of heart disease. Like, is it just reducing, the plaque on your ultrasound and your cervical arteries, or are we actually reducing events, cardiac events, heart attacks, strokes, things like that? So there's a lot of there's a lot of observational data. There are some randomized controlled trials, but it's most of those are in oral forms of estrogen. We don't have as much information, frankly, on transdermal estrogen, which is what most people use these days.
Yeah. So this is one of the things that I'm also understanding, is that the form of replacement matters, right? Because the trial that sort of black boxed hormonal therapy, right, for a very, very long time was recently looked at, and the black box warning was removed. So how would you tell women patients, at the time when black box warning was still there, and now that it is removed, what do you want them to know to understand this? Because I have to tell you that a lot of women in my practice, women with established cardiac conditions that could benefit from systemic hormonal replacement therapy, still have a lot of hesitation. And I think this was the trial that dominated medical thinking for a very, very long time, 20, 30 years, whatever that was, has sort of left its mark.
Yeah. Well, the Women's Health Initiative 2002 was the big study you're referring to, obviously. And, they were looking at Premarin, or conjugated equine estrogen, which is, as we call, kind of a synthetic. I don't like that name so much, but a synthetic estrogen. It doesn't match what your body makes. And they also were looking at a synthetic progestin, which was really the big problem causer in a lot of that. But that combination also caused some problems. So the things that they saw that they were concerned about, they saw an increased breast cancer risk. We know that was from the progestin. That was not the estrogen.
Mm-hmm.
That was the progestin. As far as the heart goes, they did see an increased risk of heart attack and stroke in women who started hormones more than 10 years from menopause onset. So women, for the heart attacks, at least the heart attacks, these are women who had been off of hormones, had menopause, no hormones for at least 10 years, many of them more than 10 years. And then they started this oral estrogen, oftentimes with progestin, and these were synthetic forms. In those women, they saw an increased risk of heart attacks in that first 2 years. Mm-hmm. After that, they actually saw reduced risk of heart attacks, which is interesting. In the women who started those hormones early, they did not see an increased risk of heart attacks. So I think that that's a key point, is even the synthetic versions, which we consider now to probably be not as safe for most women because they do increase blood clot risk, that oral synthetic estrogen. Even in that population, the women who started early did not have increased heart attack risk, mm-hmm. and actually may have had some reduced risk. So that, but once people get the word that it's going to cause heart attacks and strokes and breast cancer, and then dementia was also on that list, people heard those words and they didn't care about the nuances, and they were like, I'm out. And doctors too, right?
But recently, the black box warning was removed. At least FDA advised, companies to remove the black box warning. And, that was a step in the right direction. I actually wrote about it in my newsletter. Do you think it was justified to remove the black box warning? I mean, should we still worry about the heart attacks and the strokes? And and I get asked this question quite often, is there any age relationship? Like, for example, if a woman wants to start, as you're mentioning, within that near-term menopausal window, let's say 10 years or so, which is typically what I believe the Menopause Society advises, what if there is a reason to start it and she's beyond the 10-year mark and she's somewhat older, what would be a safe and a good way to give this patient an opportunity to choose among available options?
Yeah, I mean, the real problem causer was the synthetic estrogen and progesterone started later than 10 years, or in people who have known cardiac disease. That was the real problem. The safest version is in someone who either has known cardiovascular disease or is more than 10 years from menopause onset and isn't sure, is just to do a transdermal estradiol, which is the bioidentical form given through the skin, and a bioidentical progesterone. And that combination has never been shown, as far as I've seen, and maybe you've seen, but I've never been shown to increase cardiovascular disease, heart attacks, strokes, or blood clots. So any of those three things has never been shown to be a problem with transdermal. Now, I will say on the flip side of that, we also don't have any good studies that I've seen that if you start hormones more than 10 years-ish from menopause onset or already have heart disease, that giving those hormones is going to further reduce your risk of future heart disease. So it may be that with the heart, there really is this, this sweet spot in terms of when the hormones are most effective, when the receptors are able to, kind of bind them in the blood vessels and create meaningful change. It may be that. However, the hormones are not going to be dangerous if given transdermally and they're bioidentical, as far as we know.
And so this is a very valid point, and I think it's super important because the route of delivery matters, right? And the level of risk matters. And I think, cardiac risk, one of the things that I learned, with my experiences with hundreds of patients is that as much as we make cardiac risk a priority in cardiology, because we always do, we have those, population-based calculators and guidelines, and it all evolves every single time, we are not able to truly personalize risk because, these are population-based level metrics. And, the moment you use them, they are sort of the floor. The problem with traditional cardiology is that a lot of cardiologists think that they are a ceiling, and they're not. They're the floor because these other factors, especially for women, maybe a little bit less for men because the men don't really go through menopause, but especially for women, these other factors play enormous role, genetics, level of inflammation, level of oxidative stress, how detoxification happens. And now we have these cardiac imaging techniques that can literally show us a composition of the plaque in the coronary artery wall. You can certainly see carotid, but, coronary coronary arteries. We can actually measure plaques, measure their composition, measure flow. So I think we've come a really long way. So let's say from patient perspectives, because patients are always, curious and they're considering these types of therapies, especially since now, as you mentioned, a lot of more mainstream gynecologists are able to prescribe it. What do you think, what do you look for in your patients clinically in, specifically cardiovascularly to give them advice if they should lean towards starting hormonal replacement therapy or not? Like, what are your sort of, your pattern recognitions, right?
Well, I am generally a fan of hormones. So I will just say, like, unless there's a contraindication, like a hormone sensitive cancer, a recent breast cancer that was hormone sensitive and you can't have hormones, especially if you're younger, 50, 60, 65, somewhere in that range. I'm generally a fan of hormones. I think that the benefits far outweigh whatever risk there might be in most cases. I think that for women, as you mentioned earlier, during the perimenopausal transition, so many things happen from like a metabolic standpoint, from a mitochondrial standpoint, from an immune system standpoint. Inflammation increases, and all of those play into increasing cardiovascular disease risk, right? Like your mitochondria, which are the energy producers of your cells, all of a sudden they're not working as well because we don't have estrogen. Same thing with your immune system. It's not working as well. You've got increased inflammation because you don't have estrogen. And then so we see increased blood pressure. We see increased heart, we see increased blood sugar. We see increased inflammation. And all of those things, of course, lipids are all going to then increase cardiovascular disease risk. So I think that the question is more, is there a reason that I shouldn't take hormones? Versus what are the reasons I should? Because the reasons that you should, if you ask me, are pretty long. The reasons that you shouldn't are if you have a specific, history of cancer, a fear of hormones, and you just really don't want to. It's your choice, obviously. But those are really the main reasons. Even blood clot risk. Now we think that transdermal estradiol is safe. So to me, there's a lot of benefits.
Interesting. So what are your top three in the should box, right? So we know what the shouldn't, shouldn't box is pretty clear cut. What are your top three in the should box?
So for cardiovascular disease risk, I would say reduction in inflammation and helping to control the immune system. I would say improvement in lipids, although not as good as some medications, certainly, but we can see improvement in lipids, especially with oral estradiol. Frankly, it works better than transdermal for lipids most of the time. And then I also think that it's hard to quantify, but improvement in mitochondrial function, which of course is going to affect every cell in your body, including the cardiovascular system.
Yeah, so this is very true. And, I think what I'm seeing also on my end is that the cardiometabolic angle is much more difficult with hormonal replacement therapy, probably because the difference in forms, right? Oral versus transdermal, especially when it comes to estradiol. So we're not necessarily seeing a great impact on lipids. It's highly variable. Yeah. And women who are starting it with because they've been found to have dyslipidemia are probably going to be disappointed because the major driver behind that dyslipidemia is insulin resistance, is cardiometabolic. And so this is where we need, to figure out our insulin sensitivity, change our diet, achieve better body composition, and so on and so forth. But with regards to other things, and I think that's where the story is more nuanced and a little bit more interesting. And I'm curious as to your opinion, how do you define perimenopause? Because, I have a cardiovascular definition of perimenopause since it's, sort of vague, right? Women come in with a multitude of symptoms, but very often I start thinking of hormonal replacement therapy for women when they are, 40 or older. They are not technically menopausal. Most of them aren't. But they are having issues with blood pressure fluctuations. So they don't necessarily have hot flushes, right? But they do have these labile blood pressure or blood pressure that, just starting to sort of, go up from normal. And, we know about 25% of women in menopause they have early hypertension. So I'm wondering, are you seeing this? Is it your sort of clue to really give them an opportunity at, hormonal replacement therapy, especially transdermal estradiol, even though, and do we have any evidence to show that it has an impact on blood pressure or anything blood pressure related?
Yeah, great questions. I think that last time I looked at blood pressure, the data wasn't as strong for estrogen as it is for like blood sugar or lipids. Even though lipids isn't perfect, we do know we can have some effect. Last I looked, I don't, and you would know more than me probably, but I don't remember seeing that estrogen was as helpful or as reliably helpful maybe for blood pressure. But it makes sense that it would be, because we know that estradiol it works via nitric oxide. It works to help vasodilate the various blood vessels in the system. So it makes sense to me that it would be. I don't know why I have in my mind that it's not as helpful, but maybe you can shed some light on that.
It depends, because what I'm finding is that looking at the literature is that the degree of vasomotor symptoms matter, right? So women that have intense hot flashes, very frequent hot flashes, this sign of autonomic instability is related to a remarkable uptick in hypertension, right? They could become, 32 up to 60% will actually develop hypertension. So I think removing the driver of hot flashes by kind of stabilizing hormonal fluctuations should at least down the line, we hope, impact their cardiovascular risk. Another thing is that what always comes through my mind is that, are we measuring the right things? Because some of the earlier changes with age, and it's true for both men and women are not unique in that, is that we have early changes in the heart itself. They're conformational changes, and we have changes in the stiffness of the arteries, right? Our arteries get stiffer. So I think that sweet spot that you mentioned, 10 years after menopause, the stiffness may not have fully set in yet. And so when you go to older women, you probably have missed that window of opportunity. And the stiffness is very difficult to reverse. So there is something called, when we do vascular age staging, we measure pulse wave velocity as one of the indicators, are your arteries stiff or not? It's basically like a fancy blood pressure measurement, that calculates a number for us. So, so I'm wondering whether that's what we should be measuring, and whether that should be sort of a surrogate measure. Do the hormones really work? Because if you're just measuring blood pressure numbers, there's so many things that are influencing blood pressure that I don't really think that we'll be able to have a consistent answer, but we'll have some answer. So are you seeing now that the black box warning was removed, or at least the companies were advised to remove it? I don't know how many of them sort of went through removing it. What are we seeing in terms of patients? And are there any studies that you're aware of, newer studies, that are going to answer some of these questions? Like, in other words, when experts come out, and I'm going to ask you that question, what's the estradiol level that you're aiming for women patients, right? I heard it all. So I want to hear, what are all these theories about different numbers? So let's dive into that.
So, I definitely think that I more and more people, more and more women, I think, are becoming comfortable with the idea of hormones, just because the black box warning is coming off. The FDA has said this is pretty safe. And I think also more doctors, I'm getting contacted more frequently, to just get education. The doctors who are like, I dismissed these things for a long time, but I think there's probably something I should learn about them. And so I think that is pushing this field in the right direction. And I'm happy to see that for sure. Regarding levels, I don't know of any studies going on right now. I'm sure that there are some, but I don't know, looking at the blood levels. The major organizations all say you don't need to check any sort of serum levels or urine. You don't need to check hormone levels, because they go up and down and it doesn't matter. And we just treat based on your symptoms. Essentially, the rationale being, we're giving you hormones for symptom relief. So if that's what we're doing, then all we need to do is ask about your symptoms. And to me, whether or not we know for sure what the perfect level should be for you, I do think that we need to be asking that question, because I do think that we should be giving hormones for more than just symptom relief. At the very least, we should be trying to stop bone loss, which we know 100% that estrogen can help stop bone loss. Whether we know 100% that it can also help with dementia and heart disease and all these other things, there's disagreement in the field. But if we believe that there are benefits long term, then there has to be a point where in the serum or in the urine or in the tissues where there's a kind of minimum amount of hormone that you need, right? So to me, it makes sense that to at least be checking these hormones, even if we don't know for sure what that level is.
So what is sort of like, do you have like a rule of thumb? Like, I want my women patients estradiol to be this, or I want my male patients free testosterone to be this, sort of like, what are your metrics?
So for women, generally, I like to use an estradiol of between about 65 and 150 plus picograms per ml. I think that usually is when symptoms are relieved. And we know that from the literature, as when we looked at vasomotor symptoms, usually about 100 is when most women have relief of those symptoms. And then we know it from bone studies that, that somewhere in that 65 to 150 is just generally where a lot of the bone loss stops and bone building starts. We don't have as much data from other studies, but that's where I generally am targeting. But I'm also looking at all these other indirect measures of estrogen, because, of course, your estrogen is going to go up and down a little bit throughout the day, depending on when you're taking it and what sort and what form. So I'm also looking at all the other markers like bone resorption markers in your blood and your, inflammatory markers and your lipids and all these other things that can be affected by hormones. And then for testosterone in men, testosterone, I generally like to be kind of middle to upper end of the reference range for both total and free, really. But we also know that in both men and women, testosterone is a little tricky in that symptoms certainly matter more than serum values, and those things don't always coordinate all that well. Sometimes, you have pretty low T symptoms, but your testosterone is 500, 600. Sometimes you feel great on a testosterone of 500 for men. So I think there's a lot to learn still, but usually I'm looking at kind of upper end of the reference range.
And I agree, because I think that, we typically tend to focus so much on women because there's much more complex needs and regimens for hormonal replacement therapies. But for men, this is very true. Men could have various numbers and they don't necessarily correlate with the symptoms. What do we know about testosterone therapy and cardiovascular risk in men? Because this is also controversial, right? Because some of those veteran affairs studies that were done said, no, we can't do this, So had this, what were the prior studies, and had this thinking evolved, for in the more contemporary era?
Yeah, well, the short version is that testosterone is very safe in men. They actually removed the black box warning last year for most things, like blood clot was a risk on the black box warning previously, heart disease. Now it's just high blood pressure. So they changed it to too much testosterone can increase blood pressure, which I think is true, but got rid of the increased heart disease and blood clot risk. We've had a lot of data on men, honestly. Testosterone has been used in men for a long time. The studies that caused problems were from like 2013, 2014. There were 2 studies that were poorly done, including one of the studies actually included women in the study without even knowing that they're women. Like they were women. They took a bunch of data. Some were women. And they parsed it out and said testosterone increases heart disease risk, which, and they went back later and were like, oh, wait, these were a bunch of women as well. So anyway, it were bad studies. Since then, we've had some pretty big studies, including the one that came out. I'm blanking on the name. I think it starts with a P. The prostate, the cardiovascular one that also looked at prostate exam. Do you know the name of it? I can't think of it.
I'm blanking on it I will find it and I'll put it in show notes.
It just came out like blanking a year or two on ago. The name. Big study, looked at cardiovascular disease, looked at prostate disease, looked at all the things that people worried about with testosterone, and none of those things were true. The only thing that was true was potentially increasing blood pressure.
And so what is the mechanism of testosterone? How does it increase blood pressure and why? Because I have to tell you that even with DHEA, some patients increase their blood pressure, right? This is something that we should know. And DHEA is actually technically a supplement. It's not even prescription based. People can get it off the internet.
Yeah.
So, which I don't think should be happening, but it is happening. So what are the mechanisms?
Yeah. I actually don't know what the mechanism is. There's thinking that potentially because testosterone can increase hemoglobin hematocrit, right. That maybe that increase in erythrocytosis is causing increase in blood pressure.
So hyperviscosity, the red blood
I think that makes sense, and that's probably part of it. I don't know if testosterone also works on the aldosterone, renin aldosterone pathway. I know both estrogen and progesterone do, so maybe that's part of it as well. But I don't know. And I don't see high blood pressure in most men on testosterone. It's something that's pretty rare. But if I have someone who has a high hematocrit, then we're working on dose. Maybe he's donating blood, but we're making sure that we're checking blood pressure on that as well.
But in general, if you have a patient who is a man who is already hypertensive, you probably will be more concerned about starting testosterone in this patient.
I think you have to just make sure you're watching it and make sure that you're ruling out other things that might cause both hypertension and low testosterone, like sleep apnea or something, some sort of hypoxic situation that could cause both of those things. So I think
cardiometabolic. I think male patients, patients who are men, underappreciate the impact of insulin resistance. This is such a, sort of perennial issue. And, I honestly believe that, aging starts when the body begins to turn insulin resistant, right? It has the tissue levels and then becomes systemic, depending on exactly how you let it progress. So there's such a fundamental pathway that if you don't undo that pathway, you're going to, unfortunately roll downhill. So very interesting. So let's talk about a couple of other things that are sort of top of mind here. We talked a lot about estradiol. We talked a little bit about testosterone. How do you see the role of progesterone? Right, because progesterone usually comes along for the ride, right? So what does progesterone do? How it benefits women? Is there any cardiovascular relationship? What can we discern, at least from the stuff that's already been published and maybe discussed?
Yeah, progesterone, I think you're right. People think of it as kind of like a throwaway hormone. Like you have to take it because, in women, if you have a uterus and you're taking estrogen, you have to take progesterone as well because it protects the uterus from the estrogen. But, progesterone is a really important hormone just in general. And it's kind of the yin to estrogen's yang. Like I think of it as like helping, estrogen is kind of like go, 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 go. Like it's like proliferative and it's like doing all these things and it's building and it's, sometimes it's going a little crazy. And to me, progesterone kind of comes in. It's like a project manager to estrogen. It's, it's like, what? Let's not go so crazy. Let's like chill out.
Let's put the brakes on. A little bit of the brakes here.
Like, let's do this in a controlled way. And we see that in breast tissue. Of course, we see that in the endometrium and the uterus. And so, we also see progesterone is very important for brain. It's a neurohormone that gets made into allopregnanolone and other hormones that are really important for anxiety relief and calming and sleep and a lot of those kind of things. So I think, any woman who is taking estrogen, I like to have them take progesterone, whether they have a uterus or not. The bad thing about progesterone is in some women, they just don't tolerate it very well. There's, about 10 to 20% or so of women just don't do well on progesterone, especially oral progesterone. And so then you got to figure out, can we give it a different way? Can we do a different dose?
So in what way they don't do well on progesterone? What are the signs and symptoms?
So there's actually 3 different ways. There is the first category where they're just more sensitive to progesterone than other people. So like most women, like you take it before bed, you sleep well, you wake up and you're fine and you go about your day. But people who are more sensitive to it, they may take one progesterone before bed and they wake up groggy and they can't get up and they're just like, their mood is low and they just feel like, they're so tired. So that's one category. And then there's kind of the opposite category, what we call paradoxical progesterone response, where it actually, that progesterone, when it goes to the brain, it binds to the GABA receptor. And instead of calming you down, it excites you. It's not the progesterone's fault. There's something going on with your, in the head. but it excites you. It can make you insomniac. It can make you anxious. It can make, you can feel like really revved up, like not in a good way. And so that is one possibility. That's those 2 are the most common. And then the rare case, there's actually a progesterone allergy, which doesn't happen very much. It's maybe 1% of people or less, but that is an actual allergy, IgE mediated, lips swollen, rash, face swollen, like in that case.
So, but that could happen with any medication, right?
Yes, 100%.
That's, and, or even as nutritional ingredient. Very, very interesting. I actually think that progesterone is more beneficial for blood pressure control than estradiol in transdermal form, because one of the reasons being is that this overall calming effect, reduction of anxiety, we do know that unfortunately the hyperadrenergic response, the high cortisol response that, synonymous with middle age, especially with menopause, it has a tremendous role in blood pressure elevations. There is actually in the more traditional medicine, there are all these tests, for Cushing syndrome and everything else. And I'm thinking to myself, you don't have to have Cushing syndrome. You just have to be chronically stressed like most people are in regular life, and you will see the blood pressure impact. So no need for Cushing syndrome. It starts at a much, lower rate. So interesting. Now, what are your thoughts on using testosterone in women? Is there any, what are the usual reasons you would use it? Have you seen the same cardiovascular issues that sometimes occur in men, issues related to rising hematocrit, hypertension, and so on and so forth?
Yeah, I'm a fan of testosterone in women. I don't think that all women need it. I think it's a little different in that your ovaries and your adrenal glands both continue to make testosterone after menopause. So it's not like you have this fall off a cliff like you do with estrogen and progesterone at menopause. Testosterone starts going down, just like with men, at about age 25, and it just kind of marches slowly down as you get older. But some women, really continue to make a decent amount of testosterone into their 60s or 70s. So I don't think everyone needs it, but I do think it can be really powerful and helpful for those who have low testosterone symptoms, which can be, anything from low libido and sexual symptoms to, even things like brain fog or lack of motivation or poor muscle building and things like that. When you look at the major recommendations from major, menopause organizations and women's health organizations, they recommend testosterone only for treating hyposexual desire disorder. So, low libido, low sexual problems. They recommend testosterone in some cases for that, but they don't recommend it for anything else. But I think that they're probably a little behind what we're seeing in clinical practice, which is that a lot of women benefit from testosterone, even if it's not just sexual problems they're having.
It's interesting because, one of the keys to unraveling insulin resistance is building muscle mass. And so this, obviously, estradiol and testosterone effect on bone and muscle is pretty profound. And so, so it does have these, cardiovascular implications, even though they may not be direct, but, but it works through body composition. It also works, obviously, improvement in mood, improvement in sexual activity, increase in libido, having sex, let's call it for what it is related to improved cardiovascular health. You actually have to have a certain amount of cardiovascular ability in order to do this. It's still 100%. It's still a physical. Yeah, the blood flow is real. It's still a physical, a physical exercise. Although maybe not hit, but it's still a physical exercise. So there's definitely room for it. So how would you, one of the things I think I'm struggling with this as a practicing physician, and I know my patients are struggling with it. There are so many choices. There are so many options. What is the advice other than looking at, ChatGPT or Gemini? What is the advice that a patient could actually listen to? Where can they find more information? How can they educate themselves? Because this is such a complex area, right? And maybe you can talk a little bit about your sort of philosophy of this hormonal optimization therapy, or HOT, right? So what are the steps? What are sort of the milestones in that road, so that patients understand, well, that's how you're supposed to think about it, and I need to align with that or trial it for myself.
I wish I had a good answer for you, but it's really hard because ChatGPT, all the AIs, I use them every day, but they do not get a lot of this right. So some of that, they go based on everything that's out there on the internet. And so they're pulling random stuff and they don't really always understand the nuances. They also, they'll oftentimes just kind of speak whatever the party line is, like whatever the major, organization says on this, then they'll be like, this is what it is. And sometimes, I don't think that's quite right. I think that, there's a lot of information out there, like on social media and Substack, and I have a Substack if you want to follow along, but unfortunately, we don't know who to trust, right? Like, we don't know who, and everyone's telling you something different. Like, everyone has their own way of doing it and their own nuances. So I really think, talk to your friends, get doctor recommendations from people that you trust if you can, and then try to find a medical provider who, at least is open to talking to you and giving you their perspective and not just kind of shutting you down when you ask questions.
This, I have to say, this is so important, right? And Menopause Society has some information for both patients and providers, is where you can find. Definitely Dr. Amy's Substack is tremendous. You can learn a lot from it. Now, you also have a course for professionals, correct? You want to tell the listeners about that? It's only for professionals. So if you are, a patient listening to it, I don't think it will be good for you, but maybe down the line, you'll make a course for patients. But there's certainly a course for professionals that you have that I'm taking, and I am enjoying it.
Oh, good. Thank you. I call it hormone optimization therapy, or HOT, because I think that it's a little bit more like we're trying to optimize hormones, not replace them. And we're not just doing menopause, we're doing other things, men's hormones, perimenopause, PCOS, et cetera. But yeah, it's for any medical professional. I've actually had, women's coaches and things like that who know a lot about this space, who've taken the course. But it does, there are some parts that go pretty deep into the science weeds. So it may not be for everyone, but if you are an NP, PA, physician, anyone like that who wants to take it, come visit my website and I can direct you to it.
Or just a very, sophisticated consumer. And we're getting a lot of very sophisticated consumers who have done their research and they want to learn more. And so that would be a great opportunity. And you also have a book coming out in 2026, right? I
do. I'm writing a women's longevity book right now. And it's actually women's longevity through the lens of reproductive aging, ovarian aging. There's a lot of discussion of hormones, of course, but it's not just hormones, but it's kind of like, how were women kind of set up? Why do women live longer than men, but then spend more time in poor health? Why are women not being studied, even though we live longer? There's some questions like this, which I think are really fascinating, but it won't be out until early 2027, but certainly I'm excited about it.
That's amazing. And, and I think it's important for women who are listening to us and for men, of course, but, especially for men who care about the women in their life. One of the things that often doesn't get discussed is that heart disease actually kills 10 times as many women than breast cancer. Just think about it. 10 times as many women as breast cancer. And I'm shocked at the fact that we have tremendous gains in breast cancer screening, mammography, ultrasound, breast MRI. There is now AI being applied to mammography, but we really don't have a paradigm for vascular screening for women, which absolutely blows my mind. So I invite any woman, if you're 40 or older, please ask yourself, what can I do to understand my vascular health? It's actually not complicated. You don't need super fancy blood work. There are tons of great genetic tests that you can get at really good price point. You can get coronary calcium score. You can get, carotid ultrasound. There are so many things that you can get so that, you shouldn't just be getting annual mammograms. Every time you get that annual mammogram, ask yourself, did I screen my vessels? Because they're 10 times more likely to kill me than the breast cancer. So, so this is my message of hope and, dedicated to the Americans Heart Health Month, and, hopefully will improve the lives of our listeners. Dr. Amy, this was tremendous. I am going to put the links to all of this that we've discussed, your Substack, your book. You probably don't have a link yet, the study that we mentioned that we're both blanking on, our senior moment here, but, but in terms of hormones, I think that hopefully this information can put some women at ease so that at least, the mindset will shift more toward exploration as opposed to just saying, well, no, my doctor said I should never have it, because that is actually not true. The key is to find the regimen that works for you. Find, personalization opportunity. Thank you so much.
Thank you.
Thank you for tuning in to Own Your Heart Health with Dr. Regina Druz. This podcast is powered by Holistic Heart Centers. If you enjoyed the show, please rate and review us on your favorite podcast platform. To learn more about our services, visit holisticheartcenters.com and subscribe to our YouTube channel. The link is in the show notes. See you next week.